I'd like to welcome everybody and thank everybody for joining us for this podcast entitled Generations of Regenerations. This is a podcast that is being conducted by the Osteoscience Foundation. I'm Dr. David Sylvester, and first I'm going to introduce myself just a little bit. I'm an oral and maxillofacial surgeon. I'm practicing right now in St. Louis, Missouri. And a little bit about me, my journey. I started off actually as a piano performance major, of all things. I like to say I kept it in the ivories. That's one of my own little jokes. But I went to college, the conservatory first, and then undergrad in Kansas City before going to dental school in Kansas City. And then I attended the University of Oklahoma for my residency training, where I met Dr. Sullivan for the first time in 2012 when I had my interview. And then I completed my residency there in 2017 before going into private practice full-time in St. Louis for Clear Choice, focusing primarily on dental implants and full arch implant rehabilitation. And then also had the opportunity to work as an assistant clinical professor at my alma mater, the University of the University of Oklahoma, where I got to work again with Dr. Sullivan, but this time from the clinical standpoint. So I've had several years of the opportunity of working with Dr. Sullivan, first as a resident and then as a fellow faculty, and I would like to say a mentor-mentee relationship throughout the entire process. So I have the privilege of introducing Dr. Sullivan. A little bit about him. There's a lot to say, so I'm going to keep this really condensed. But originally, Dr. Sullivan got his bachelor's degree from the University of Northern Colorado and then headed down to Texas at Baylor to do his dental school training. And he finished in 1983. And that's just 2 years before I was born. For his training in oral and maxillofacial surgery, he attended OU starting in 1984 and then finishing in 1988 before going abroad and doing some fellowship training internationally. And for that, he went to the University of Melbourne. He did a fellowship in the Plastic and Maxillofacial Surgery Unit at the University of Melbourne and the Royal Children's Hospital before coming back to the US in 1989, where he was a faculty at the University of Michigan for 1 year, and then was recruited to the University of Minnesota, where he led the maxillofacial trauma surgery service in the Department of Dentistry. And then for reasons I'd like to ask him about in a second, he decided to come back to the University of Oklahoma in 1992, where he was recruited as the program director and interim chair of the Department of Oral and Maxillofacial Surgery. Now, at the time, he was the youngest chair in the United States, and only 31 years after that, he was, I don't want to say oldest because he's not the oldest, but the most senior chair of any OMFS program in the United States. So he stepped down as chairman recently, but in no way has he slowed down as he continues to maintain his private practice. So a few of his accomplishments, there are many. He's been a board examiner for ABOMS, president of the Oklahoma Society of Oral and Maxillofacial Surgeons, president of the Southwest Society of Oral and Maxillofacial Surgeons. And one thing I want to highlight that a lot of people talk about and people ask me questions about when they find out that I trained with him or I worked at OU. Dr. Sullivan was the architect of truly one of the most innovative faculty practice models that you will see anywhere in academia. And what happened was in 2005, the faculty practice at OU was privatized, and all the faculty members were able to hold their existing faculty positions, but their clinical practice was completely independent from the university. Now, to this day, Dr. Sullivan continues to practice, and he limits his practice to corrective jaw surgery and TMJ construction, which are two of the things that he is the most passionate about. And he lectures and speaks nationally and internationally on these topics. So, today's discussion and topic, we're talking about generations of regeneration. The Osteoscience Foundation is all about bone regeneration or the regeneration of tissues. I think it's kind of ironic here that we're talking about a mentor-mentee relationship. Almost, how is it that we regenerate some of our past mentors? Maybe in some way I am some regeneration of Dr. Sullivan in a younger form. We know that when it comes to bone regeneration, the more of that native bone or the more seeds of that native bone or native tissue that we have, the more similar of a product that we're able to produce. So, maybe I'm a Sullivan blast, or maybe we'll be talking about some of the Sullivan blasts that have been cultivated in relationships over the years, and maybe those turn into Sullivan sites. Maybe there's a little bit of barrier membrane regeneration in the process, but we're going to be focusing really on this mentor-mentee relationship, and I'm going to have the privilege of asking Dr. Sullivan several questions and really just leading some discussion as we talk about this and we talk about his journey through oral surgery. So the first question I would like to ask you, Dr. Sullivan, is, let's talk a little bit about your career path as an oral surgeon. Let's talk about what drove you to this, and let's find out how exactly you ended up in Oklahoma.
Well, thanks, David, for a very nice introduction. And clearly, you and I have become very close, not only friends, but not only colleagues, but close friends. Traveled together, had taken some very exotic trips to Africa, and enjoyed our company on safari and what have you. But that's an interesting question because I look back at my career and how did I end up in dentistry in the first place. Oddly enough, my dad wanted to be a dentist. He wasn't much of a risk taker, and I can remember as a young high schooler, him pushing me, saying, you got to think about being a dentist. You got to think about being a dentist. And I said, I don't know, Dad, maybe I need to be a lawyer. And he's like, no, go be a dentist. You have a lot more flexibility. You'll enjoy that. And I really didn't realize that he was pushing that direction because that was really his aspiration. But by the time he got through the Navy, got through his first 4 years of college, he had 3 children, my older sister, myself, and a younger sister who's 3 years younger, living in a little Quonset hut in Fort Collins, Colorado. I think he felt really compelled that he needed to go get a job rather than, undertake 4 more years of dental school. And I think that's something he really regretted. And so it kind of, the seed got planted early, and I kind of just chose that path. Ended up when I was in high school and in college was a big game hunting guide, which people don't really picture me being an elk hunting guide. They kind of think of me in different terms. And fortunately, I've got Peter Larson, who was a year ahead of me, that I did take elk hunting, and I made a believer out of him. Wore him pretty slick one day on horseback. But bottom line, I met a guy from Texas who was a dentist that was hunting, and I told him I wanted to go to dental school, and we kind of hit it off. And he said, I'm going to write your recommendation. I'd love to have you come to Baylor. Ended up at Baylor. First couple of years, did not like it at all. Could not see myself as a dentist. I got kind of ingrained and involved with the oral surgery folks kind of by accident. I had to put myself through school. So I worked in a very nice high-end clothing store at the time. And Miro Pavelka.
Can I just say you've got a very nice suit on.
Yeah, if you can't be good, look good. But no, interesting. When I was a second year dental student, I was working in this clothing store, and Miro Pavelka, who went on to become president of AAOMS, was a resident at Baylor at the time, and we struck up a friendship. And he kind of got me interested in doing oral and maxillofacial surgery, and that was probably the start. This was pre-match days, and so it was kind of a scramble at that point. Interviewed at Oklahoma, interviewed at Houston, interviewed at San Antonio, Baylor, what have you. Actually got into the program in Denver, and I just didn't like it. I was to be in the class with Peter Larson. in Oklahoma, and they lost one funded position. And I got a call from Dr. Markowitz, who was the chair and program director, and says, "Hey, if there's any way that I can redshirt you for a year, we'll bring you in the class of '84." So I said, "That's fine. I'd rather do that than go to Denver." So, worked as a general dentist for a year, hated every minute of it. Yeah, and matriculated in '84 with Peter Larson a year ahead of me. Jim Swift was my chief resident at the time. And so, interestingly enough, Oklahoma really kind of fostered three people who I think made a pretty big impact on our specialty in academics. I left after I finished, did my training in Australia, as you mentioned, was on faculty at Michigan, then Hennepin County at Minnesota, and then I got the fateful phone call when the program director and chair, Bob Markowitz, left the program. And they were really scrambling to find someone because the program was grossly underfunded. They really had a budget for faculty of $112,000 for the entire faculty, and I was I guess think I may have been their last pick, as it turned out. I would hope to think I was their best pick, as looking backwards. But I looked at it as an opportunity because the word on the street was, if I didn't go back to Oklahoma, they were going to close the program, and I did not want to see that happen. So I came back here in June of 1992, and we were completely bankrupt. We had this little tiny budget. We had no faculty, and it was a daunting task, to say the least. But we fast forward 30 years, and we're incredibly successful. We're probably one of the most financially solvent programs on the entire Health Science Center campus, definitely in the dental school. And as you alluded to, in 2005, we moved our practice out of the college into a private setting on campus, made some concessions with the university, but at the same time made some commitments that we would do several things. One, I said we will double our output on surgical experiences for our residents. I said I feel that we'll be in a position to bring in $1 million in new revenue to the College of Dentistry, because at the same time we moved our practice out, I moved the resident clinic out of the hospital into the college. And all those things came true. By 5 years, we had generated about $5 million in new revenue for the training program. It was robust. It was financially set. We went through and completely remodeled all the facilities, including the predoctoral facilities, at no cost to the college, really as a goodwill gesture, in them making the right decision to let us branch out and kind of do our own thing. And it's been very good for us. I think that we've been in a position to do all the things that we told the administration we would do. Our clinical output for resident training is probably nearly quadrupled in the 20 years that we've been in that setting. We've recently added a fourth resident to our incoming group, and we'll look at that going forward as now being a 4-year per year residence program. So I mean, lots of good things, but those were all done really out of necessity, because they weren't going to provide any more money. They basically told me, "We're tapped out. You're gonna have to make your own way." And I said, "Well, if you're going to make me make my own way, then you give me the tools, and then you stay out of my way." And thankfully they did, and it's been wonderful ever since. I've had the great pleasure of hosting folks from training programs around the country who come up to look at how we do things, how we model our practice. I mean, we run a faculty practice with a 24% overhead, which is just absolutely unheard of in a 3,600 square foot practice, and generate as much as major departments do, in the medical school. It's really quite ironic, but it's a testament to our people.
You're going to make people start crying, and when they're listening to this, that are in private practice, listening to overhead numbers like that, because it truly is unheard of. And I will say, you are the most enigmatic oral surgeon figure that I've ever become acquainted with. And you've been a great mentor of mine. Before I talk about some of those things, um, and ask you, and honestly get some of your perspective on how I have viewed you as a mentor. Let me first ask you, who were some of the biggest mentors that you had in those early days, one of your training? Who were you, latched onto, looking to
Yeah.
emulate, looking to be, and what kind of relationships did you have and foster with them?
Yeah, that's a good question. 'Cause when I started as a department chair, I was appointed at the age of 35 and kind of took the reins a couple months later. So I was 36 when I became department chair. I was old as some of well, as the orthodontic chairs, one of his children. I was the same age as one of his kids. And when you looked at me on executive committee at the hospital, I was the youngster of the group, and so and honestly, I had no mentor. I this was a it was I was on the job training for the most part. I mean, I had guys like John Helfrich in Houston that I could kind of talk to a little bit. Peter Larson was a year ahead of me. He was always a source of inspiration and a source of that I could call on just kind of from programmatic sorts of things. But from a clinical standpoint, I really didn't have any mentors. My program director had largely, retired at that point. And I had the great fortune in 1996 of becoming friends with Johan Reneke, who is, I think, one of the world's premier, now retired orthodontic surgeons. I mean, he retired with nearly 10,000 orthodontic surgery cases under his belt. I'm still trying to catch him. I'm at about 4,000. I don't think I'm ever going to catch the guy, but nonetheless, it's always been an aspiration. But Johan was really an a clinical inspiration for me. And I've become pretty good friends with Larry Wolford over the years. I mean, he and his wife and I were in dental school about the same time. So I've known Larry for a number of years. Philosophically, we've got some similarities, not completely, but I think Johan Reneke is probably one of my biggest sources of inspiration from a clinical standpoint, from a departmental chair leadership standpoint. I didn't have anybody. I kind of had to mold my own and forge my own path, in that regard.
So it sounds like for the most part you were a bit of a pioneer.
I kind of got thrown in the deep end. I just had to sink or swim, and I'm pretty resourceful.
Well, yeah, that's true. But it's the opposite for me, in that regard, because I trained under you. So I from day one, well, I really didn't operate with you much until my third year. But I, I was there, scrubbed in with you, watching you operate, watching you cut your side, trying to laser focused as much as I could to try to emulate every move that you did. I mean, me and I know every other resident, just the same as me. When we were in the OR with you, I mean, it was 100% our goal. Some would joke the goal was not to get yelled at, but really the goal was to try to emulate every single move that you made with such precision. I mean, hands down, you're the best surgeon from a technical standpoint that I've ever seen, cut the procedure. And when I would be splitting a case with you, I'd be watching every move that you made. I'd be watching how you held every instrument, and trying to emulate, you from like a mentor standpoint. And here we are now, I mean, 7 years later, and you still haunt me. I mean, there are times I'll be operating on a case and I'll get that periosteal and I'll reflect, the soft tissue, and I will have think that I've done enough reflection and I'll keep moving. And then I've all of a sudden I've got to ask for the periosteal back. And I hear you in my head just shouting at me, over the patient. No wasted movement. I hear those words all the time, and I still try to emulate it. And mind you, I mean, I'd like to think I've gotten pretty darn good, over these 7 years and over all this experience. But for me, and for a lot of the residents that you trained, that's how it started. No matter how much we would all make jokes in the resident room afterwards, or whatever possible, disagreement anybody might have with you on any kind of a school policy or like a personal setting, when it came to operating with you and watching you in the OR, everybody wanted to emulate to exactness like your skill. And with that regard, I think that that you've been a really strong mentor for, well, how many residents have you trained at this point in time?
Oh gosh, probably close to about 100, and I guess if they're hearing my voice while they're operating, then I've done my job well.
So I said 100.
Yeah, we probably trained about 100 residents, roughly between Michigan, Minnesota, Oklahoma. I've been here 32 years. We've not had 3 per year for all 32 years, but probably 65 to 70 Oklahoma residents, and then 3 or 4 years after. So yeah, somewhere between 80 and 100. I'm guessing. I'd have to really sit down and do the math, but a lot from all over the place.
Can I tell you that walking around this country, there are 80 to 100 people that all have their own take on doing a Dr. Sullivan impersonation.
Well, I'm sure
Some
they do. Yeah,
some are
yeah,
better than others. Some are,
yeah.
some are better than others, every single one of us in the resident room would have our own version of a Dr. Sullivan impersonation. So along these regards, I want to talk about this, and I think that there's different levels of excellence. You're one of the few people that I've encountered that excel in all of the categories. And let me clarify what I'm saying. So, when it comes to dentistry, there's a business side to the dentistry. You can have some people that are great at the business aspect, but their clinical skills might suffer. You've got some people that are fantastic clinicians, but they're not good mentors. They're not good, academic people. And then there are others that are great at teaching, but maybe they fail in the other departments. Um, I've seen you excel at all three, and uniquely, because for the most part, and I can say this as a faculty member at the University of Oklahoma, they say if you can't do, teach, right? So it's rare to find that crossover, and that kind of excellence that can exist in all the different areas. What's been part of the motivator for you, and what have you wanted to really impact on the residents? What's the biggest thing that you've wanted to impact on the residents that you've touched and taught over these past?
Yeah, I think the most important thing for me is number one, their whole role as an oral and maxillofacial surgeon is taking care of the patient and taking the best care of the patient as they possibly can. Because if they do that, everything else absolutely falls into place. When I was a second year resident on neurosurgery, I've always been impacted by Don Reinhardt. He was a kind of one of the godfathers of neurosurgery in this community. And we're operating, and he made the comment to me one day. He goes, Steve, he goes, you should never get worried about the financial aspect or the financial riches that our professions will bring us. He goes, if you will just always do the right thing for the patient, that takes care of itself. And I'm a firm believer of that if you always do the right thing for the patient, everything else follows that, because that reputation precedes you in every aspect. And so you'll enjoy personal success, you'll enjoy professional success, you'll enjoy a very comfortable living that you can provide for your family and do things for others. So that's probably one of the things that I really want to impart on residents is just take care of the patient. And if you do the right thing, you will be taken care of. And then I think the other thing is become technically sound, because the more technically sound you are, the more efficient you operate, the less likely you're going to have complications. The quicker you get through the procedure, the faster the recovery, the better the patient feels. And that comes full circle, that if the patient felt good after a very successful procedure with a great outcome, they're going to come around and tell people that. And I have folks all the time, especially my revision patients, that I've seen from all over the country. they come back and they'll show me a picture. This is what I look like after my first orthodontic surgery. This is what I look like after yours. Night and day difference, and a lot of it is just that execution that that you learn, that our current residents learn, where there's no wasted motion, efficiency, precision. Getting through a double jaw in an hour and 15 minutes, hour and a half, hour and 45 if you're talking about closing and cleaning things up a little bit. That transcends really to a great outcome for a patient. Less swelling, less pain, less anesthetic related issues and those sorts of things. So I really stress those sorts of things about efficiency and personalizing the procedure for that individual and aiming for the best possible outcome.
I gotcha. Yeah, and I mean, I've spent countless hours with you in the operating room, and kind of getting a chance to witness that clinical, well, what I'll call clinical excellence. I have to ask you this though, especially after leaving, teaching residents, working with residents, working with different assistants, just it can be a revolving door sometimes, without a lot of consistency. Did you? I mean, we used to joke on new rotations that it was like Groundhog's Day, right? The movie, because a fresh set of guys would come in. You do the surgery the exact same way, which is something I've tried to emulate when I do my surgeries. My assistants often comment that I'm extremely predictable, and I want nothing more than that. I want to be extremely predictable. You do the surgeries the exact same way every time, but yet you constantly have a new set of two residents that are not used to your style coming in every 4 months or so, right? With a rotation change. I mean, did you ever, when you were starting all this out as a chairman, did you anticipate this, and why would you want to do that?
Oh, you mean have rotations of residents and stuff,
Yes, yes.
yeah. Well, that's
Somebody.
part of that's what you signed up for. You signed up for that, and I'm a creature of habit when it comes to stuff in the operating room, and I for some reason think everyone can read my mind sometimes, and that's obviously not the case. But yeah, it's challenging, because even the third year that's been already on my service and has watched 100 sagittal split osteotomies in that 4-month period. And you kind of assume, well, they've watched 100 of these things. Surely they've figured out what the sequence is. But when it's them directly across the table from me, and I do my side and they do theirs, it's just like it's entirely different. It's one thing to be a golf caddy, and it's another thing to be a golfer. And I think that's probably the thing that I just still have a hard time kind of getting my head around, is that I got new people all the time, and though they've seen a sagittal split 100 times before they actually get to do one, you can't assume that they know and remember those steps when it actually is them doing it. They can recite it, but they haven't done it, personally. So it's totally different. So it's part of the territory. You've got that rotation. I get over it pretty quickly. We get into the groove pretty fast, and the faster the resident picks up the routine, the more fun we ultimately have, because as you know that once that little bit of newness wears off, then it becomes just a real pleasure to do those cases, because you're not talking about the big stuff. You're talking about the little nuanced things that I see that you don't see, that I go back and point it out to you, and you're like, those aha moments about making the medial cut on a sag and making a dip of the saw in a way to make the Hunsuck split go just a little bit cleaner. Little things like that you probably don't notice that I do, that I go back and I point it out to you, and then it becomes one of those moments you go, all right, that's the pearl that's going to help me when it's my turn. So those are the things I think once we get past the newness, that's the fun part of working with residents.
I think you just picked the easiest side to do, because it takes you how long for your side for a sagittal
Well,
split?
sad? Oh,
Yeah,
5 to 7 minutes.
and it takes the residents longer than that. So I think it's just a matter of cherry picking the easy side. You're
Yeah, I
right.
always do the right side because I'm right-handed.
You're right-handed surgeon, and
Yeah.
I'm a right-handed surgeon on the left side.
Yeah,
It only,
amazing how that works.
it only, yeah, it makes sense. Well,
Chairman's prerogative.
what's been the most satisfying part for you of the teaching aspect?
Oh, I mean, go out and I see almost every single resident that we've trained is really kind of excelled in their private practice setting, and seeing them flourish. I think in going out and emulating what they've learned at OU in their private setting, and coming back to you and go, God, I went back in with this partner and I kind of showed him some tricks with whether it's orthodontic or whether it's learning clefts from Smith or things from Tawana or whatever. Them being able to take that experience and apply it not only in their private personal experiences in practice, but also maybe influencing their partners and associates that they've got. I think just kind of it kind of expands the OU footprint, for lack of a better word. So I think that's probably the neat thing is we've got folks from all over the country that are kind of doing things the OU way and then come back and talk about it.
Oh, it's so true. I'm so proud to tell anybody that I trained at the University of Oklahoma, because I feel like I got fantastic exposure, and I got a fantastic training experience, while I was there. So, for sure. Now I've got to ask, what is, a piece of advice, since what we were told earlier is that the average age demographic, the people that are listening, are in training, or they're in 20s and to 30s, and you're not in your 20s and 30s. You're a little bit more seasoned within life and within the oral and maxillofacial surgery community. I mean, you've seen this entire specialty transform so much
Mm,
since your very first days.
mm.
I mean, my God, even just rigid fixation on the mandible, for instance. But if you if you were talking to some of these young bucks, people that are considering oral surgery, people that are thinking about residency, what kind of advice would you have for this next generation, that are on the complete opposite end of the spectrum?
Yeah, one of the things that concerns me a little bit now is I think that the industry, and I say industry, plating companies, this, that, and the other, implant, I think they've got a lot of undue influence on the direction that our specialty takes. And I'll name one specific thing. These patient specific plates that they're selling that are $7,000 for a plate to fix the maxilla so that you don't have to use a splint. Pre-fitted plates on the mandible, all this sort of stuff, where it's almost paint by colors. I really, really fear that residents are going to rely so heavily on that they aren't going to truly know how to do the operation. And there is such merit to that. There's the Instagram surgeons who, are out there promoting, yes, and I use custom plates on everybody, and I do the surgery in X amount of time, and da 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 da. Oh, I'm seasoned enough to realize they can really only use those in certain instances. And those instances don't fit every single patient, yet they're using them on every single patient. And I think that the young residents need to look at our specialty as a bit art and a little bit science. That surgery itself has some artistic aspects to it, and I think that it's founded in science. But the things that we do, whether it's placement of a dental implant and getting that beautiful emergence profile, that's the art in what we do. And you can't do that unless unless you really perfect your own craft. And it's the same way with orthodontic surgery. I mean, it's not really the operation that is so critical. It's the treatment planning of the operation to get that beautiful aesthetic result, then executing it in a way that facilitates attaining what you've planned. And I think that unfortunately, we've kind of gotten to this paint by numbers by these plating companies that are saying, yeah, if you just do this, this, and this, we're going to make your life easier. You just show up, you cut it, we make sure it's in the right spot. Well, I'm going to tell you something. It's not always in the right spot. I mean, I've seen way too many of these patients on revisions that they look absolutely ridiculous. And what's occurring is these young surgeons don't know how to do it conventionally and have a check and balance when it comes to the new way of doing things and knowing that, hey, this isn't quite right, and I recognize it's not quite right because I know how to do it the old way. It's just like we had you tracing analog cephs before we had you doing
What are you talking about
virtual
before?
surgical planning.
I never did virtual surgery. I did 100% analog.
That's right. That's right. I did that on purpose. We transitioned right after you.
Yes.
That December, we went all to virtual, but to this day, our residents do an analog tracing because they learn the mechanics. And then when they get on the VSP, they've got a check and they've got a balance. They know that things are working out the same way. And I've asked every single resident for the last 7 years, do you still find value in doing things that way? And they go, yeah, it gives me a sense of security that when I do the virtual surgical plan, it matches what I did with my own two hands. And I know that I've got things where it needs to be, and I trust the aesthetic. So for the young surgeons out there, don't get lulled into a false sense of security by yes, we're going to have you put this implant in with a robot, or hey, we're going to put custom plates and screws and you never have to look back. Your orthodontic surgery is always going to be exactly right. It's not true. Always be skeptical, always strive for perfection, always try to find a better way to do things, and always look at your results and be critical of yourself. That's probably one of the things that made me a better surgeon, is from the time I was a resident, even to this day, I will take my prediction tracings, my VSPs, and I'll look at those and I go, did I hit the mark? And if I didn't, then I sit back and say, well, why not? What can I do better to make that, to provide a better patient experience and better outcome, for the patient? And David, I don't do anything like I was trained. I don't do anything like the same as I did sometimes 6 months ago. I'll tweak things to make it just that much better for the procedure, to make it go quicker, make it more accurate, those sorts of things. So I think that you gotta grow as a surgeon. You're a perpetual learner in this profession. And that's one of the things I think that I would stress for our young surgeons out there is it ain't over the day you graduate. It's just beginning. And so always be critical thinking, always be looking for a better way to do things, always look for a better outcome for your patients, because those are the kinds of things that are going to bring you professional satisfaction, personal satisfaction, and practice success.
And I'm going to piggyback off of that. So there's something that you said that reminded me. You talked about looking at post-operative x-rays and critiquing your own work. And one thing that surprised me and also really impressed me, my chief here when I was on your service, is I do remember, well, I guess I had the impression that you made me do all of your dirty work, right? I had to trace the ceph, do the model surgery, take it to you for approval, send you a photo of whatever, whatever model work I had done, get your approval. But I was doing the brunt of the dirty work, and you were rightly so, you'd earned it. But in my mind, you show up, you do the surgery, we have all your expertise to bail us out, and God forbid anything happened in surgery. But I remember seeing you at a follow-up, and you were evaluating a post-operative x-ray, and you were looking at the split, and you were looking at it just very discriminately, and it looked great to me, and it was actually on your side. But you were pointing out, you should look at the x-ray, and you're pointing out to me how you could have done something just a little bit better. And to me, I really didn't notice the difference. I mean, it looked like a good looking post-operative x-ray, but it did impress upon me that, I guess, after so many, of arches of this surgery that you had done, you still were taking the time to not just look at the x-ray, but, and perhaps in a moment of vulnerability, you were in front of your chief resident pointing out that you could have done something better on your side. It wasn't, you berating me or telling me that, I had a bad split or something on my side. In this particular scenario, you were talking about yours. Yeah, I'm sure there were plenty of other times when it was my side, but go ahead. What were you gonna say?
I was gonna say the last bad split that I had was with you,
I don't,
and it was on the left side.
oh, couldn't have been on the left side. You must have taken over.
No, I'm dead serious. Someone asked me the last time I had a bad split, And I said, last bad split I had was with David Sylvester sometime in 2017. And so, you figure 150 double jaws a year times 7 years. That's not a bad record for bad splits.
No, for sure.
Sorry, it was you, my friend. Couldn't happen to a nicer guy. But
Well,
we didn't miss a lick. I think you remember that patient. We didn't miss a lick. It did, but pop. We fixed it. It added another 10 minutes to the procedure, and we were, it was boom, boom, boom. Everything was good. So, and I learned something out of it, and you did too.
and I couldn't agree more with the artistry component. And I completely agree. I do a ton of full arch all on four surgery, and I I see a lot of this digital technology, and I think it's fantastic. But there is no substitution for when the guide doesn't fit or when something goes wrong. Being able to do it and troubleshoot it and understand the analog process. And dare I quote you right now in saying that some of these things are elegant solutions to non-existent problems.
Yeah, yeah. I mean, yeah. I mean that's one of my and actually I stole that term. I think it was Kim Goldman, or Goldman or Goldberg. I can't remember her name. We were at an AO course back in the day when they were wanting to do endoscopic condylar fractures, and there was a huge rage. That was the latest and greatest thing to do in the early 2000s, and now you hear nothing about it. And why is that? Because it was incredibly hard, didn't improve outcome. Some of those cases took 6 and 8 hours, were no better than doing an open procedure, et cetera, et cetera. And she made the comment with us, this looks like an elegant solution to a non-existent problem, because you can treat them closed, you can treat them open, minimal morbidity, but it's actually true. I think sometimes we outthink ourselves, and we find a technology that's supposed to make things so much better, and all it does is add significant expense to the cost of treatment. And I really worry that we're going to kill the goose that laid the golden egg, because I've already got hospitals asking me, hey, you do these corrective jaw surgery cases, and your plating costs are $1,200 to $2,400 for a double jaw, and this guy in this local hospital just did one, and his plating cost was $30,000. I go, yeah, you use patient-specific plates and splintless surgery and cutting guides and all those sorts of things. So if we're not careful, hospitals are going to say, you know what, we don't get paid enough, we don't need you, and we're going to limit how much we're going to allow you to do in an operating room setting if you can't be, good stewards of resources. And so I think the younger generation really needs to be cautious about, how they spend other people's money, especially insurance companies and hospitals and so forth. Otherwise, it could come back to haunt them.
Yeah, it sure is a privilege to be a part of this specialty, and you know, I couldn't agree more. There's a huge artistic component which I love. I mean, I think we all picked dentistry, whether we liked general dentistry or not. We all picked it because we have a creative aspect and we like working with our hands, and we got to be careful not to outsmart our own common sense. So, hey,
Agreed.
as we kind of wrap this up just a little bit, we've been talking pretty clinical. Let's finish things off just a little bit on just a personal note, on a Dr. Sullivan, like personal life. What are some things you like to share that about you, about your personal life, things that you do, your hobbies? I
Yeah.
mean, I already know them, but tell us a little bit about the Dr. Sullivan
Well,
who goes home from work.
Well, my purpose in this specialty, purpose in life, is really my family. I've got an absolutely delightful wife of nearly 32 years, Veronica. We met when I was in Minnesota at the University at Hennepin County Medical Center. I've got three absolutely spectacular daughters. Oldest daughter, Catherine, is a fourth year dental student here at OU, and is top in her class and applying to orthodontics. My middle daughter was one of the Hunt Scholars at SMU and completed that program a little over a year ago, and is working with Cigna Group the large insurance company in Dallas, and I'm crossing my fingers we can get her home to Oklahoma because we sure miss her. And then my youngest daughter is Elizabeth, and she is will be a junior down at OU and is doing digital marketing, and currently is kind of doing a on-the-job internship that hopefully will transition into something permanent with American Fidelity Insurance here. That's a company Bill Cameron owns, and who's a delightful, incredibly passionate and great guy. So that's really the most important thing in my life is all my girls. I've got a niece in Tulsa that really is my fourth daughter that we've kind of taken under her wing. Her father unexpectedly passed away, and he was like my brother from another mother. And so they've got two children, which we're kind of their grandparents. So we spend a lot of time with them. But my hobbies, I'm a gun aficionado. I've been collecting in the last couple of years bespoke English rifles, particularly Holland and Holland rifles, and have a number of those. Actually, I got into that with one of my total joint patients has about 120 bespoke handmade Rigby's Holland and Holland Wesley Richard rifles. So I'm learning a lot about that. And as you know, I'm a passionate dangerous game hunter. Having been to Africa about 7 times, just got back a couple of weeks ago. It took you, and that was absolutely one of the highlights. Spending 10 days with you in the wilds of Niassa in Mozambique was just absolutely delightful. I had so much fun with you and my brother-in-law and our friend Tim. So that was really cool to expose you to that. But those are the things I like to do. I hand load and shoot a bit and those sorts of things. Love to travel, but love to travel mostly with my girls. That's always a good time.
Absolutely. Well, hey, Dr. Sullivan, thank you so much. One, for everything that you taught me, for your mentorship, and it's been a real pleasure getting a chance to sit down with you in this little podcast. And thank you to the Osteoscience Foundation for putting this together. Yeah, thank you so much.
Well, it's been entirely my pleasure, David. We're just incredibly proud of what you've done with your career and how you've managed it and the expertise that you've acquired over the years with dental implants. And thanks to Ashley and Osteoscience Foundation for this opportunity. It's been a real passion of mine. The profession's a passion, and I'm passionate about everything that I do, and I really appreciate what they do for the profession in their space, and I want to thank them. And if there's anyone out there that has any questions, wants to follow up on anything, I would just welcome your phone call or email. I'm not hard to find.
All right. Until next time.
Thank you all.
To learn more about Osteoscience Foundation, visit osteoscience.org or follow us on Instagram, Facebook, and LinkedIn.